Good evening, everybody. Dr. Sudhir Kothari will be joining us in some time. He asked us to start the program. So, Dr. Sudhir, you can start.
Yes, sir.
Make it a slideshow.
Yes. Good evening, everyone. So today I'm presenting a case of a 38-year-old female. She is a right-handed individual, educated up to 12th grade. She had passed the 12th grade. Uh, Currently a homemaker and also does daily wage work in a farm. She's a resident of Purandar and Hindu by religion. History was given by herself and her sister-in-law, which is reliable. She presented with the chief complaints of pain in the right shoulder, which started 2 years back, slowness of activities, difficulty in walking since 2 years, and tremulousness of the right hand since 6 months. My patient was all right 2 years ago when she developed pain in the right shoulder, which was insidious in onset, gradually progressive, a deep aching type of pain in the right shoulder with worsening of pain on moving her right shoulder. Initially, she felt it in the early morning hours after waking up and attributed it to her sleeping position, but gradually the pain started worsening on washing clothes and hanging them out to dry, and it was present throughout the day and night. There was no radiation of pain, and there was no relief on application of hot or cold application. There was an associated feeling of stiffness in the right shoulder and the neck. She consulted a local doctor for the same and was prescribed analgesics, which relieved the pain temporarily. The pain continued to gradually progress and worsen over the next few months. While working in the fields, her relatives noticed slowness in her activities. She was unable to keep up with others while walking in the farm. On trying to catch up, she felt a fear of falling both forward and backwards. While taking like harvesting, she used to take more time than before to pick up vegetables. She took more time in making rotis at home. Over the next year, relatives noticed that she had become significantly slower and she used to remain in the farm beyond sunset trying to complete her day's work. She could now do only about 50% of what she used to do earlier. Now she couldn't make the pleats of a sari and started taking her sister-in-law's help. Combing hair and brushing teeth took longer. Eating had become slower. She takes more time in breaking the rotis and feeding herself. She took more time to get up from a sitting position and on standing felt some instability. So she used to take support of the tables or the wall. Since 1 year, she is unable to climb upstairs without support. She takes a lot of time to do this activity. She has stopped wearing saris and uses gown. She walking on level ground has become slow, and relatives say that she takes very short steps and has developed a forward bend as well. And on calling out, she moves her entire body to turn while walking. There are no history of episodes of freezing while walking. She doesn't bump into objects. There's no sudden increase in speed while walking. These symptoms are associated with 2 episodes of falls in the last 1 year. So the first fall, she fell while getting up from a sitting position and fell forward due to loss of balance. And as she did not have anything to support herself. The second episode of fall, it was a backward fall. This happened while she was climbing upstairs. This fall, she had sustained a small abrasion on the scalp. The patient developed tremulousness of the right hand since the last 6 months. It was present at rest, seen as a slow pill rolling movement in the fingers. There were also movements at the right wrist and the elbow. They were not present on doing any activities. There was no spillage of tea while holding the cup initially, but off late she complains of some spillage. There was no smearing of the face while eating food. It was not present while trying to reach an object, or neither was it present at sleep. There was no associated voice, head, neck, or jaw tremor. There was no abnormal twisting movements, posturing of the hand. And there was no diurnal variation, no tremulousness on the left hand or the legs. Since 1 year, my patient, she prefers to stay alone and doesn't interact much with her other family members. She has stopped watching her favorite TV series. She keeps to herself and feels sad about how she takes more time to do her activities of daily living and about her dependence on her sister-in-law for doing all her activities. She also feels sad that she can't cook for her children. There is no history of forgetfulness or socially inappropriate behavior, food cravings, impulsive or repetitive behavior, inability to do simple tasks. There is no episode of any self-harm, no history of hallucinations, delusions, or acting out her dreams. There is no history of loss of consciousness, headache, vomiting, or seizures. No visual complaints, loss of facial sensations, facial deviation, difficulty following nasal regurgitation, coughing or choking episodes while eating food or water. There's no history of abnormal or loud sounds on sleeping, no weakness in any limbs. There's no history such of urinary or bowel disturbances, or any sensory level in the body or loss of sensations in the body. There is no history such of profuse sweating, palpitations, dryness of mouth, or giddiness episodes. There is no history of fever, weight loss, loss of appetite, night sweats, no trauma to the head, no exposure to chemicals or pesticides, no history of chest pain, breathlessness, abdominal pain, altered bowel habits, blood in urine. Past history, there's no history of diabetes, hypertension, tuberculosis, bronchial asthma, ischemic heart disease.
Okay, go back to the first slide.
Yes.
So, second slide. Yeah. Second slide. Oh, this. The first complaint you're addressing is a pain in the right shoulder. So, anybody wants to ask any questions from the attendees? Anybody wants to ask any question about this particular complaint? She's 38-year-old and developed pain in the right shoulder. Anybody wants to ask any question about this? I think Arohi, you can analyze this and tell, unmute yourself, and what do you think about this pain?
Yes, sir. So this pain is lacking pain entities and having restriction of movements which worsening. It's more of looking like a frozen shoulder.
Okay, but your origin, the pain
Non-radiating,
is
so
from where?
not a radicular.
It's not a radicular pain. Is it inflammatory pain?
No, not a radicular pain. That is it.
No, radicular pain is different.
So no swelling, and it does not have application of cold or hot.
Okay.
So
how do you recognize?
Not a radicular pain since
not,
it's
oh, radicular pain we understood it's not. Then what is this then? Frozen shoulder because of what? It's over now 2 years, no?
Yes, sir.
stiffness.
Stiffness. That's because of stiffness. Okay.
Why do people get frozen shoulder?
Oh, that's important. Yeah, Sudhir has joined. Nice. Good. Why do they get? She is a farmer. She was working in the field.
What are the causes of frozen shoulder that you know of? Common.
I think Sudhir, you pick up a person and ask. Otherwise, they are not answering.
Sorry. Okay. So yes. So Divya Teja has rightly said diabetes. Diabetes is if somebody comes with frozen shoulder, diabetes is one cause. If somebody has a fracture, let's say of the right upper limb, and you put it in a cast, and after 2 weeks, 3 weeks, you remove it, the shoulder is notorious. If you immobilize it for even a very short time, it will get frozen. And therefore, something which triggered it. What is a common condition that we have which triggers reduced movement of the shoulder?
Stroke.
Stroke, yes. So many times you get what is called CRPS, and part of it is frozen shoulder. But if you don't pay attention to it, then they will get even complex regional pain syndrome affecting the hand also. So always look out for that. And then what else cause reduced movements of the shoulder?
Anything about the ligaments?
Somebody has written there. Somebody has written Parkinson. So think of Parkinson always. If you have somebody with unexplained frozen shoulder without an injury, without a stroke, just like that, if they got, check their sugar. If the sugar is all right, then check their gait to see if there is reduced arm swing. So I don't know the earlier history of this patient, but this is
this is the first slide.
Okay.
Show the first slide, Srihari. Yes, these are the.
Okay. So then I think we've already got the diagnosis, no,
Yes.
from this.
Second complaint is slowness.
Yes.
It's a 38-year-old lady and slowness. So somebody can analyze this and tell what are the red flag signs in this presentation.
There is gait instability. I mean, she's having a fear of falling.
Okay.
And the slowness has progressed over 1 year. It has become significant. It has reduced activity by 50%. And it is affecting our ADL, activities of daily living.
Right. In Yon and Yar staging, how the disease progresses, anybody can tell? If you think it is Parkinson's disease, how will it? Somebody unmute. Yes.
Initially unilateral, sir.
Unilateral and
then develops unilateral and axial involvement, and after 2 years, usually bilateral.
2.5 is it will become bilateral. Somebody is answering. Yes.
When do they get affection of speech? When do they start falling? After how many years of Parkinson, roughly?
So 3 years.
3 years. 3 years is too early.
Yeah, it's too early. I think maybe after 5 years they start.
5 to 6 years.
Yeah.
First of all, is it Parkinson? 38 years. What is this
38.
Parkinson
That
disease or
itself
not?
is a red flag, correct?
Yeah.
Yes, sir. This is young. No, sir.
Don't say young onset. What is it? Is a Parkinson's syndrome, right? You have to establish the diagnosis. So, what are the red flags to diagnose Parkinson's disease?
So red flags, like if when you have symmetry of symptoms, or when there is rapid progression, early falls, or like if you have stridor, and if you have like reduced eye movements, then if there is cognitive problems, hallucinations.
Okay.
Correct.
Right.
Good.
Then antrocholis, and then emotional debilities, or if the patient is having behavioral changes.
Autonomic
dysfunction is
early in the course of the disease, if you have dementia, autonomic nervous system disturbances, hallucinations, gait abnormalities, all these are red flags to go. Good. Sudhir, shall we go to the third complaint?
Yes.
the progression. There are 2 episodes of falls in the last 1 year.
Okay.
And then in the last 6 months, she developed tremorlessness of right hand, resting tremor, no other tremors.
How do you approach tremor? What are the questions you ask to analyze tremor?
Sir, if it is first, we have to ask if it is seen during action or at rest. If it is present bilaterally or unilaterally, if it is affecting the patient in her daily activity, like if there's some smearing of the face while eating food, or spillage, then we have to ask if it is present in any other part of the body, head, neck, jaw, the voice tremors.
So importantly, whether disabling tremors or non-disabling tremors. Does it make any point there?
This is actually non-disabling.
So what does it mean to you? If it is non-disabling tremor, what does it mean? Anybody else can answer. If the tremor is non-disabling, what does it mean to you? It is a disabling, what does it mean to you?
So disabling usually essential.
Yeah, please tell.
So disabling, it can be essential tremors when the patient is not able to.
Disabling tremors are essential tremors. Okay. Tremor at rest and Parkinson's disease tremor or Parkinson is non-disabling, but they are tremor at rest. Proximal tremors are disabling, rubral tremor is disabling, cerebral tremor is disabling. But Parkinson's disease tremor is not disabling. That's one of the important. Which part of the body face is not involved in Parkinson's disease tremor? You said they got
jaw.
voice, head, neck, jaw. So, which is not characteristically involved in Parkinson's disease. Anybody?
These are usually not involved in Parkinson's.
Jaw is involved? No, no
No,
problem.
sir.
Lips are involved, jaw is involved. Which
No,
part
sir.
is not involved?
Legs.
Legs are involved, sir. It
In
can be involved.
face.
In face, jaw is not involved.
Jaw can be
My
involved.
class left.
You can get like that
Okay.
in Parkinson.
Head is not involved in Parkinson's disease. Most important. So
Voice is not involved.
voice is not
Don't get a
involved.
voice tremor.
Voice, head not involved, and jaw is involved, lips are involved. Okay. Tongue is involved. Next.
Then she developed some.
If the person comes with a history of tremor, but when you examine there's no tremor, what will you do?
Examination point.
No, somebody saying re-emergent tremor, that is different.
That is different.
So count backwards. So basically, what are you trying to do? You're giving.
To see if it is.
You're giving
to distract.
Some not deviate. You are stressing out the patient. You have to cause. This is not distraction. You are giving some stress. See, for majority of people, counting backwards, 100 minus 7 is stressful. You have to start thinking after 93. What is next? So when they start thinking and they see everybody's looking for, then they start getting this tremor at rest, and you'll see that. So either that or ask them to count the months backwards. So this is not distractibility. Distractibility of a tremor is in functional tremors. In Parkinson tremor, you are trying to stress. So often they might give you the history that when he's sitting alone at home, there's no tremor. But when there are a lot of visitors or he's anxious, that time we'll get. Now, how do you get the patient to become anxious in your clinic? One way is ask them to subtract.
Count backwards or subtract. That's excellent point. Everybody should learn this. Okay.
Yes.
Why did you ask hallucination, delusions? What is in your mind?
So, like for Parkinson plus, we have to rule out DLBD. Hallucinations can occur in DLBD. Then cognitive decline.
So, what type of hallucinations you see in DLBD?
Yeah, they are very peculiar hallucinations.
So visual hallucinations usually involves like they see children or animals.
Yeah, Lilliputian and
yeah, insects is not too common. But yes, children, some benign sort of, they are not scared of the hallucination. And it is called, is there a word for this small children or small old people? Anybody's?
Somebody written.
Lilliputian. Yeah, so you all have I don't know if you all have read Gulliver's Travels.
Yes.
Gulliver goes to Lilliput where there are all these small people there. So these are Lilliputian and often they don't scare them.
What are the diagnostic criteria for diffuse Lewy body disease? Important points. 1 or 3 for 4.
Sir, fluctuations in cognition.
Fluctuations, how frequent is fluctuation? What do you mean by fluctuation? Is it in a day, in a week, in a month, in a year? What is fluctuation?
So during a day, they will have fluctuation. They will have neuroleptic sensitivity, hypersensitivity.
Okay.
And they will have Parkinsonism and visual hallucinations.
Do they have falls also?
Falls.
Oh, yes, right. They have frog. So what is the pathophysiology of these two diseases, Parkinson's disease and what is important?
Sir, like alpha-synucleinopathy or like tauopathies, like two categories are there.
What is this? disease, Parkinson's disease and DLBT.
Alpha-synucleinopathy.
What is alpha-synuclein?
So it is protein aggregation within intracytoplasmic protein aggregation. It forms
Misfolded proteins.
Yes.
Okay. Go to the next slide.
Where does it form first?
Where is synuclein? Where is it formed first? Which part of the brain? Or which part of the... Where is it coming from?
It starts from
Where?
like olfactory or brainstem, then ascends up to cortex.
What is the importance of gut in this?
Anything? Yeah.
Gut origins of gut microbiota dysbiosis theory is there.
Not microbiota. Something else in the gut.
Is it a prion disease? Is it a slow virus, slow prion? What is the concept of synuclein?
So Bragg staging, there is like initially they say it is from it can originate from the gut and then traverses upwards through the brainstem or olfactory and then goes to the cortex.
Okay, what are all synucleinopathies?
Multi-system atrophy. Then there is a pure autonomic failure, Parkinson's disease, DLB, and Parkinson's disease dementia.
No, that's okay. I think you have covered most of them. MSZ, DLB, PD, and pure autonomic failure. Right?
Even idiostatic orthostatic hypotension. I mean, like primary autonomic failure.
That's what is the PAF somebody has written also. That's correct. So what are tauopathies then?
Tauopathy is progressive supranuclear palsy, corticobasal syndrome. Then fixed disease, frontotemporal degeneration, then argyrophilic brain disease.
Okay. So there's a different PSP and CPD, corticobasal degeneration. What is this 332? Somebody saying, what is that?
What's that?
I don't know, somebody's written 332, I don't know what it is. Okay. So the autonomic nervous system disturbances, how did you take the history?
So one is when the patient has, like if they have profuse sweating, palpitations, dryness of mouth.
But what is commonly
occurring? When they stand, they usually have a postural drop in the blood pressure. So
yeah, giddiness and getting up, postural symptoms that somebody has said. Postural symptoms. So what are all the non-motor manifestations which you can encounter?
So loss of smell can be there. There can be depression, anxiety. They can have autonomic disturbance, constipation.
Pain. The most important.
Pain, bladder.
Pain. Bladder.
Urinary incontinence.
Erectile dysfunction.
Erectile dysfunction. Yes.
So they get incontinence.
Sleep disturbance.
Do they get incontinence or retention or what?
So incontinence.
They don't get incontinence. They get urgency. Frequency.
Frequency, yes.
Frequency and urgency. So often it can be mistaken for prostate.
Yes, sir.
But not retention.
Yes.
Not incontinence.
Then they'll have sleep disturbance, RBD sleep.
What exactly is RBD?
The REM behavioral sleep disturbances. So there'll be history of acting out of dreams.
What happens what is different from Parkinson's than a normal person? About the dreams. I mean, what is different?
Vivid dreams. They'll have
Why don't you act out your dreams? Correct. So normally in REM sleep, what happens? What happens to the body in REM sleep? Everything is atonic,
Atonic.
except the eyes. The only thing that is left is the eyes, which can move. Everything else is atonic and sort of paralyzed.
Yeah.
So that's why a normal person will not act out his dreams. Can you tell me a condition where the person gets hallucinations but is not having atonia? What is that? A sleep disorder.
H से start होता है.
The person is going to sleep or is just come out of sleep, thinks he's paralyzed, but is getting hallucinations or feels he's paralyzed. So
Somebody wrote already.
hypnic paralysis, hypnagogic hallucinations, all these are sometimes formed fruits of this narcolepsy, but it can be seen in normal people also.
And what about the dementia part? Cognition in this case?
There is like no, she's not given me, there's no forgetfulness history.
Okay.
And, only thing is she's having some depressive symptoms.
Okay. So by this time you realize that she is a Parkinsonian disease, Parkinson's disease or Parkinson's syndrome. What did you think? But you almost completed the history.
It's a Parkinsonism, but just that she's very young and she's having more of unilateral symptoms.
Those who are present, can they differentiate tremor onset Parkinson's disease from akinetic rigid syndrome type Parkinson's disease? What are the major differences? This lady started having tremor early in the course. Dopa response.
Yes, she had actually tremor after 3 years. Initially, it was neck pain and then slowness of activities. Yes.
Okay. So where you get cognitive impairment early in the course? Out of these two, tremor, predominant Parkinson's disease, or akinetic rigid type? Which progresses fast? Which progresses slowly? Tremor becomes slow to progress. That's good. No, their cognition is affected. Akinetic rigid progresses fast. That's correct. Sudhir, anything else?
Yeah, I think
We'll go ahead.
Covered it.
Yeah, next.
There's no past history.
But do you think any of the toxins, what are the secondary causes of Parkinsonism? What all you can think?
Head injury can be seen in boxers.
Boxers, yes.
Then exposure to manganese, then MPTP.
Okay, right. Most important, drugs.
Drugs, yes.
Yes, drug-induced Parkinsonism.
Drugs, yes. Antipsychotics.
What drugs do you know which can cause Parkinson's?
Antipsychotics.
Yeah.
Benazine.
Typical antipsychotics, not atypical ones, but atypical also cause, but less often.
Typical antipsychotics. Then antiemetics.
Antiemetics.
Which antiemetics?
Which antiemetics? Ondansetron. Levosulfuride. That's actually.
Levosulfuride.
What are some other causes? Quickly. Somebody said manganese. What else? Metoclopramide. Yes, that's correct.
Flunarizine and calcium channel blockers also given long term.
Yes.
Flunarizine, flunarizine.
Typical antipsychotic, beta histine, stemetil, metoclopramide. Mind workers.
Beta histine doesn't cause. Somebody wrote beta histine, that
yes.
doesn't cause.
Okay. What else? Any hypoxic insult?
Hypoxic.
Which poisoning causes hypoxic damage to the brain?
Carbon monoxide.
Carbon monoxide. Yes, very good. What did Muhammad Ali?
Boxers due to chronic
Yes.
traumatic infection.
Yes, punch drunk syndrome and boxing. The most important, what is common in India is vascular Parkinson.
PDs.
Vascular dementia pugilistica. Good. So, what are the Parkinson plus syndromes which you should think?
Sir,
Young age group.
MSA, so in young age.
MSA. Quickly go on the list. MSA.
PSP, CBD, DLBD.
Yes. Yes. What else? Any movement disorder in young, what should you do? What should you think?
Wilson's we should do.
Wilson,
Yes. Should never forget Wilson's. Any movement disorder in younger age group, we should think of Wilson's. What else?
Then
Some accumulations.
We can iron accumulation.
Yes, iron accumulation. What else? NBIA, somebody wrote. That's correct.
Neuroacanthocytosis.
Okay. Alcoholics, this comes out toxic. Autoimmune, rarely. Sudhir, what do you say?
No, I've never seen autoimmune. But functional, rarely. It's one of the FNDs. You can get functional Parkinson, but rare.
SCA3 and Parkinson's disease with the ALS. Somebody said Eglon. Okay, so you have got a lot of list which you have to take, consider and take the history properly. Okay, shall we go ahead?
Tell us something more about drug-induced Parkinson.
Yeah.
What percentage of Parkinson is drug-induced Parkinson? Approximately.
Diamond picks.
What percentage? 1%, 5%, 10%, 20%? Approximately 10%.
Yes.
Somebody wrote 5, but I think up to 5 to 10%.
Dr. Partha is asleep. At least he should switch off his phone. Okay. So tell me, if somebody comes with, if you are suspecting is this drug-induced Parkinson, what will you do? Can you give him an answer immediately, or does it take time? If the person wants to know, do I have Parkinson or is it drug-induced? What do you do? Can you answer that question for him?
It is usually after starting that particular drug, the symptoms start.
Correct. So if you are willing to wait, you stop the drug. How long does it take for the drug effect to go off? 2 weeks, 3 weeks, 3 months, 6 months?
It can go in days also, like within hours also, up to weeks.
2 weeks mostly, somebody said?
No, it can take up to 6 months, but 3 months, I would say, at least 1 or 2 months. If you stop it and at the end of 1 month there is no change at all, it is unlikely.
Somebody is saying Dopapet. Has it got any role?
Yeah, what about that? What about Trodat scan or Dopapet? How does that help you?
Then, there will be uptake in the dopaminergic basal ganglia region in Parkinson's, where drug-induced it is usually normal.
Right. So
dopamine deficiency.
If it is drug-induced, the Trodat scan would be normal.
Yes.
And main uses of this DAT scan, where do you use it? One is drug-induced. Anything else? Is it useful to differentiate PSP from PD, MSA from PD? Somebody said ET, but the question is whether is it useful to differentiate Parkinson's syndromes from PD?
Maybe, may not be, but
it is must. It's used to differentiate from essential tremor. That's correct. But all these things will have dopamine deficiency abnormalities. What is the use of MIBG scan?
MIBG scintigraphy is used in, it is one of the additional diagnostic features for DLB.
DLB. What is the use? Autonomic. So that's correct. But why, which disease? MSA. Why you use it in MSA? Why not in PD? Why the scan is not abnormal in MSA? Why it is abnormal in PD? Okay. This MSA is central autonomic problem. Right? That's why it's MIBG scan is normal in MSA. Okay.
Can MRI help you in the Parkinsonian disorders? The routine MRI.
Yes, somebody said
Yes.
PSP, but
So
you had to
normal
elaborate.
Parkinson, yes, they have described swallowtail sign, etc. But I mean, you can't really use it to diagnose. At least I have never used it. So in general, it is normal.
Only a hot cross bond sign may help to some
Yes.
extent.
MSA, what do you see?
Hot cross bun.
That is one. What other sign do you see in MSA?
I see
Putaminal rim, yes.
Predominal ring. That's correct. I think this hummingbird is a very confusing thing. Right? Everything looks like that only.
But if you go by the measurements that the MRI people do, I'm never happy. I personally, the MRPI, we always have a running fight between the radiologist who says MRPI is normal, but maybe we are biased when we see. But if I see the flattening of the midbrain, that is very likely to be PSP.
Okay.
Okay. What about DLB? What do you see in DLB?
I have tiger sign NBIA. Okay. Parkinson ratio. Somebody is saying Parkinson ratio.
What do you see in DLB?
Island sign.
Yeah, which island? Cingulate island.
Cingulate island.
Yes.
Cingulate island.
What is cingulate island? Tell me. Where is it? किधर है cingulate island? North hemisphere, southern hemisphere किधर है?
Is it?
There is medial cortex.
Posterior part of?
Yeah, somewhere posterior. So you see reduced uptake in the occipital lobes, but just in front of the occipital lobe, there is this the cingulate area which is spared, and you might see it yellow or orange. So that is spared.
Yes.
Sinha has come. Welcome.
Welcome, that's Sinha, sir.
Unmute.
Unmute Sinha, sir. He is not able to do. I think that's good. We'll go ahead with the findings. Next slide.
Yeah.
The family history.
Family history, there was no similar history among family members. But there was some history of, there was second-degree consanguinity, and there were 3 males who had intellectual disability and childhood deaths.
So tell us something about autosomal dominant recessive. What are the genes? How many percentage of PD cases are genetic? What is the different age-wise classification of Parkinson's disease?
Less than, like you can have juvenile Parkinsonism.
Less than?
Onset. Less than 40 is young onset, considered as young onset. We can have juvenile Parkinsonism.
Less than 20 years.
Yes.
And late onset Parkinson's, 60 years and above. Okay. What are the genes that are involved?
So there is SNCA gene, that is then like PARK1, PARK2, then LRRK, LRRK2, then there is
These are autosomal dominant or recessive?
dominant.
Autosomal. What are autosomal recessive ones?
PARK2, juvenile.
Okay, PARK2. That's correct. What else? What is the relationship with Gaucher's disease?
Gaucher's, so that is also autosomal recessive lipid storage.
Anybody can tell about Gaucher's disease and Parkinson's disease relationship? What is the enzyme that is defective in there? There are a lot of family members of Gaucher's disease had Parkinson's disease at GBA. That's correct. So that mutant is, if it is heterozygous, people have more of dementia, and so the mutation is being now studied. Gaucher gene mutation, GBA mutation. Okay. So anything else on the family history, Dr. Sudhir, Dr. Sinha?
I think even idiopathic Parkinson, there is a little slight increase in risk with family history, but not very, very gross.
Yeah, because that polygenic inheritance. So there is some genetic counseling required if there is a family cousin is there. There is about 5% chances having a developing Parkinson's. That's what I think I read. There is some chance, as you say. It's
slight increase, maybe 5%. I'm not sure of the number, but yes, there is some little risk.
Yes. Go ahead, Srihari.
Personal history, diet was mixed, appetite normal. She was complaining of sleep disturbance, daytime fatigue, no addictions. So to summarize, we have a middle-aged female with early and insidious onset, slowly progressive, asymmetrical onset Parkinsonism, with associated depression, no cranial nerve, bowel or bladder dysfunction, no cerebellar or autonomic features, currently dependent for her activities of daily living and also having falls. Functionally, so Parkinsonism with early onset and disabling. Physiological, that tracks and anatomically it is basal ganglia and its connection, substantia nigra, and etiologically neurodegenerative disease.
You are not giving any differential diagnosis. Sudhir is saying something. So what is you don't have any differential diagnosis, only neurodegenerative. You tell the etiology name.
It can be idiopathic Parkinson disease.
What is the response to levodopa?
Later, we had done the levodopa challenge test and we had excellent response.
Achha, UK Brain Bank criteria for diagnosis of Parkinson's disease. What are the supportive criteria? Everybody knows UK Brain Bank diagnosis?
Criteria is Syndopa responsiveness, good Syndopa.
That is one point, but what are the other points?
Dyskinesia with Syndopa, levodopa.
For that, to start with asymmetry.
Asymmetry. Asymmetry.
Onset with Parkinsonism with no red flags.
Rest tremor.
Yes, sir. Bradykinesia, rigidity, and rest tremor.
Rest tremor.
If the person never has tremor, that is a point against.
Yes, sir.
So everybody should read this UK Brain Bank diagnostic criteria, and what are the exclusion criteria, what are the red flag signs, and what is supportive criteria. Right. One of the important things is, of course, asymmetry. Asymmetry remains even late in the disease. Mild asymmetry still persists. Okay. I think all the findings, Sudhir?
Yeah. How many people are members of the Movement Disorder Society?
All of them can become, I think.
Yes, it is free and you should become, because they have very good, they will have training of UPDRS, they have videos on tremor, and I think it's a very good, it is free. It is free.
It is free at $20 most.
No, it's free, completely free for India.
Free for India, and a lot of learning material there.
Lot of learning material. You must go. You must become members.
Okay, let's go to the findings.
The general physical examination, patient is conscious, cooperative, oriented.
I will post the link.
Yes.
Yeah.
Pulse was 68 beats per minute regular in rhythm, normal character condition of vessel wall, no delays. Blood pressure, there was no postural drop. 1 minute standing was 134 by 84, baseline was 138 by 80, and 3 minute standing was also 128 by 80. She had hypomimia and mask-like face. She had a chin tilt to the left. Blink rate was reduced. It was 10. There was no KF ring. There was mild pallor. No ictus clubbing, cyanosis, lymphadenopathy, edema, no other neurocutaneous markers or dysmorphic facies. Neurological examination, high mental function, was conscious oriented time, place, and person. MMAC was 28. No apraxias, aphasias, or agnosias. Primitive reflex, there was glabular tap that was present, and palmomental reflex was seen. We had done the ACE for teaching the domains, attention, memory, fluency. She scored a total of, this was a clock drawing. Total ACE score was 94. She had only attention problem where she lost 3 points and memory 1 point. Otherwise, visual spatial language fluency was normal. Speech and language, it was monotonous and low volume. Otherwise, the components of speech were normal.
Is it a dysarthria?
There was no dysarthrias.
But you are saying,
What do you think of the palmomental and the glabular tap?
They are like frontal release signs of primitive reflex have reappeared.
What is the significance of it in this patient?
Then, like Marson's sign is positive. Like so, in Parkinson's.
no, what is the significance of this? You have said they are present. So what do you infer?
The reappearance of primitive reflexes.
Yes, but is the patient showing any primitive behavior? Is there
No,
any
sir,
dementia?
no.
So
Behavior,
would you give it importance?
no, so no frontal. Otherwise, no frontal lobe.
So sometimes some normal people can also have glabular tap and palmomental positive, and I would not give it importance if the patient has nothing to suggest frontal behavior, no other sign, no dementia, no behavior problems. So I would not give it too much importance.
Somebody said more than 3 reflexes are significant. Okay. I think when there are no features, so it should not give importance. Okay.
Okay.
Next.
Cranial nerve examination was normal, sir. Only that the right.
No, most important you are missing. You have to tell everything about extraocular movements.
Extraocular
Not Parkinson's disease cases you have to describe.
Okay.
What are conjugate eye movements? What are saccadic? What are pursuits? What are convergent, divergent eye movements? So there is no escape.
Yes,
In Parkinson's syndrome, please don't omit eye movements. You have to
What is
tell.
the first thing you see in the eyes?
Blink.
So reduce
blink
blinking.
rate for
Reduce
KF ring.
blinking. Huh? Okay, then after that, when you ask the patient to keep looking at one spot, what will you see?
So we
Yes.
look for
Square wave jerks. What is square wave jerks?
Where do you see that?
PSP.
Correct. In fairly advanced stages of PSP. What are square wave jerks? Means what? Why is it called square wave jerks?
Like short.
How does the eye move? How does the eye move up and down like a square? What exactly is the movement of the eye?
So horizontally, the horizontal movement is there, short duration.
So if they are horizontal, why is it called square wave? Dr. Patel is being very inventive. Square root symbol. Yes. So Dr. Hinal is telling on VNG, it looks like a square wave. When you do a video nystagmogram, when you take a graph, you will get the shape like a square. But when you are examining, looking at the patient, it is just a side-to-side movement, horizontal. They are not saccades. They are intrusions. You ask the patient to keep looking at one spot. You're not asking him to make a saccade, but they are just intrusions, saccadic intrusions. These are involuntary movements which happen in between. So they can be seen in normal people. They can be seen in cerebellar degeneration. They can be seen in particular elderly, but they are more likely in PSP than in Parkinson. Okay, then after that, saccades, pursuit. What do you see in pursuit? If you find abnormal pursuit, what will you think of in a patient with Parkinsonism? Do you get abnormal pursuit in idiopathic Parkinson?
That's important point. No? There are no eye changes in Parkinson's disease.
You will not get. In PSP, do you get impaired pursuit?
Broken pursuit.
No. You get impaired saccades. We'll talk about saccades later. So pursuit is normal. In Lewy body disease, do you get impaired pursuit? In CBGT, do you get? No. So what is left? MSA. MSA may have a cerebellar component, and therefore you may find impaired pursuit in MSA, but not always. CBGD sometimes you might find, but usually no. Then what about saccades?
Saccades, so it can be with cerebellar ataxia. Then PSP vertical, we get vertical saccades.
So vertical means what? Upward, downward, which are more abnormal?
The down gaze is.
Sorry?
Down gaze.
Yeah, so downward saccades are slower, or the person does there's something called the round the house sign. What is round the house sign?
Somebody said.
Somebody said round the house. So tell me, what is round the house?
Moving around.
So how do you move around the house? What do you mean? Not straight, yes. So you go round.
Towards the.
You go round from, like a bracket. Instead of a straight line, you go like a bracket. Into bracket sign रहता है ना, वैसा जाता है.
Not vertical trajectory, that's Samira.
So it goes round. I can't draw it here, but something like this. It will go like that.
How do you overcome the vertical gaze restriction?
Correct. Yes.
And what is it due to? Why vertical gaze restriction in PSP? Somebody said Vivo. Because of vertical palsy, they go horizontal and up. There is no palsy here. It is a, what is a optocut? What is the
okay, you can test with that, sir.
Okay, but why it happens? What is the basic pathophysiology of vertical gaze restriction?
Dr. Saili says midbrain atrophy, but it's not midbrain atrophy. Affection of certain centers in the midbrain.
Vertical saccade center is the rostral midbrain. That's
rostral MLF.
So it's a supranuclear gaze palsy, isn't it? Rostral, right? That's correct.
I'm not sure. I don't remember. Vertical downward gaze is different and upward gaze is different. I think upward is interstitial nucleus of Kahal and downward is RIMLF.
And horizontal gaze?
PPRF.
PPRF. Okay.
And PPRF and which is the neural integrator?
The nucleus roughly.
Yeah, NPH, nucleus prepositus. Kahal is spelled CAJAL.
Yeah, that's correct. Okay, let's go ahead. So important point to in this juncture is that one is smell. You have to test in exam. On eye movements, no doubt, you have to see. Okay.
Right.
SCM taut. Now, what do you mean by that? What is the significance?
It was prominent, sir. Like the muscle was prominent, and it was like it was causing a chin tilt to the opposite side, to the left side.
The person have torticollis.
So not like there was just slight deviation of the chin, not upwards or downwards. Like it was towards the side.
Why is the SCM taut? Where do you see normally the SCM taut? In dystonia of the neck, so torticollis.
Cervical, yes. Okay.
If the right sternocleidomastoid is taut, where would the neck be? Towards the right or towards the left?
Chin to the opposite side, sir. Then
So it would go towards the left, and it would go horizontally to the left or upwards to the left.
upwards.
Yeah, if it's only sternocleidomastoid, it would go upwards and to the left. So I don't know why you're saying SCM taught. Does he have? If the person does not have torticollis, I would keep quiet about the SCM.
Do you have dystonia in
Okay.
this lady?
So like there was no movements as such, but this because of the muscle, whether it was cervical dystonia, I don't know.
No. When you examined her, did she have dystonia?
No, sir.
This lady, did she have dystonia? Did she give
No.
a history that the neck was turning to one side?
No.
Then I think best to avoid.
Avoid, yes.
Because you are going to be asked, why is the sternocleidomastoid taut, and explain why. Then unless it is so obvious that even the examiner sees it and then asks you, why did you tell me the SCM is taut, I would not talk about it.
Yes. Motor system examination, bulk of muscles are normal. She had both axial and appendicular rigidity, right more than left appendicular rigidity. There was activated rigidity also on the opposite side. Power testing, overall the power was near normal.
How do you check appendicular rigidity, axial rigidity?
The neck and back muscles. So when she's moving,
Back ka kaise check?
I'm coming. I'll do it. How we doing? Oh yeah.
Pull test is not checking back rigidity. Shoulder shake test is for the upper limbs. It's for limb rigid. So neck, yes, you move the neck side to side, flex it up and down and see is the neck rigid and compare it to the limbs. Axial rigidity, otherwise you will have to see by the posture. You can't really bend the person up and down or sideways to see his axial tone. So turning, pull test, all that is more, is not rigidity. It's gait. And pull test is?
the pull test was positive in the patient. Reflexes were normal, plantars were bilateral flexor.
So what are the grades of pull test positive? How positive was it?
Well, like she was falling on pulling back. Sometimes if
when you pull somebody back, when you pull a normal person back,
yes, sir.
When do you call it abnormal?
If they're not able to correct after 2 or 3 steps.
2.5 steps.
Okay. The gait, there was increased cadence, reduced stride length, short steps were there with poor arm swing more on the right side. The neck is also maintained straight. And while turning, the turns were slow and broken. And on pushing, there was kinesia paradox and there was no freezing. Sensory examination was normal, skull spine normal. There were no other tremors other than the resting tremor, no thickened or enlarged peripheral nerves. Other systemic examination was normal. Then we did the Syndopa challenge test for the patient. Initially, the MDCUPDRS pre-test was total was 77. Just the part 3 pre-Syndopa was 35, post-Syndopa was 14. And 12-meter walk test, there was significant improvement. Pre it was 54 seconds and post was 23 seconds. The patient was Syndopa responsive. To summarize, middle-aged female with young onset, slowly progressive, asymmetrical onset Parkinsonism with axial and appendicular rigidity, associated depression with no cranial nerve bowel bladder dysfunction, no cerebellar autonomic features, now ADL dependent after 3 years and having recurrent falls, Syndopa responsive, near stage 3. So then we went ahead with the investigation, sir. Blood reports are normal. This was her MRI brain. MRI brain was also normal.
I wish that sagittal section was a little better, but probably the upper midbrain is not flat. Probably this is not PSP. Hold on.
So clinically diagnosed as young onset Parkinson's disease. We had sent for the genetic results, which awaited, suspecting whether Part 2 or LRRP2. Part 2 because it is the most common and most common juvenile onset Parkinsonism. Suspecting.
But LARC2 is not very common in this part of the world, no? Ashkenazi Jews.
Yes.
Genetic, any idea, Sudhir? Are you getting genetic tests done?
No, I'm not. Not unless it's really very young onset, maybe below 30 or something. Otherwise, I'm not doing. But now that the genetic tests are a little cheaper, earlier it used to be 40, 50,000. But now since they're a little cheaper, around 15,000, I would do it in young onset, below age 40.
I think we should start doing it now. I think they're available now.
Yes.
Medgenome and I think we had a good discussion. Any other questions anybody wants to ask?
So I have posted the link of the Movement Disorder Society. I think everyone should become members. It is free. If anybody has a problem, let us know. It is free.
Yeah, Dr. Kothari and Dr. Gorthi, it was lovely discussion. Thank you very much. Can you hear me?
Yes,
Yes,
sir.
thank
Thank
you.
you, sir. Thank you, sir.
Yeah,
Thank you.
yeah.
Finally, you managed to unmute. Huh?
Yeah, I could. Yeah, I tried to figure it out, and finally I could unmute. See, the basic message that they have to give in is the varieties of Parkinson's syndrome that they have. When they examine a patient, the aim should be they should be able to differentiate PSP and then multi-system disorders. So they have to go into different, like many of them, the hallucination, other thing is coming in the patient of Parkinson's and dementia. Lewy body dementia is very important consideration they must have. So they have to think they're all two different diseases. The second part is the PARK2 and LARC2 that you have sent the sample. How much does it cost and who has taken the sample?
Nowadays,
Dr. Gorthi.
Medgenome is doing it for 18,000.
Okay.
All. They are doing the whole exome sequencing. So
Yes.
you don't need to ask for only PARK2 or LRK2.
Yeah, they'll do whole thing.
Whole genome only for 15 to 18,000. You can bargain a bit.
That would be relevant where there's a family history and the young onset things are there.
Yes.
Good. Lovely. Thank you very much. Thank you very much, Dr. Kothari and Dr. Gorthi.
Thank you, Dr. Gorthi. Nice case.
Okay. Okay, sir. Good night, students.